You're going to get some blood work, because with a heart attack, there are enzymes that are released as the cells of the heart get damaged. There are certain enzymes that get released into the blood microscopically, and by drawing blood and running it in the lab, they can test for these enzymes and tell that there's been damage. And there's very subtle effects of that, but it's very sensitive. And we use that test quite frequently to tell whether somebody's having damage or having an unstable angina. Angina is the term we use for when somebody's having chest pain or heart pain due to blockage, but it's not a full-blown heart attack. So ischemia is the other word we use a lot. We throw that word around, but it just means a lack of oxygen to the muscle. So when the muscle gets starved for oxygen, you get pain and symptoms, and that symptom is called angina. So we talk about unstable angina is the frequency, or it comes on at rest. Anything that comes on that easily is a big warning sign that leads us to the workup. But in the office, we're going to get the EKG. We'll either do the stress test right then, or if it needs to be scheduled, we can, and we feel like we have the luxury of time to schedule it within a day or two. We'll schedule a stress test, and there's two types of stress tests depending on the functionability of the patient, whether they can walk on the treadmill or whether we do a chemical stress test with an IV. But all of this still can be done in the office. Other screening tools, we use a calcium score, which is a CAT scan of the heart to look for calcium in the arteries. The echocardiogram or ultrasound to look at the function of the heart, and then looking at the other vascular beds, because all vascular disease tends to run together. So we will check the carotids, we will check the arteries in the legs too. So that's some of the office things that we do.
Yeah, I mean, these are all definitely, and of course, I just want to step back. One thing, there's something, that we see this often. Again, they got to get to the emergency room, and I think most people are aware, but there is this tendency between family members, and of course, if you're in the middle of nowhere, you got to get there, you will drive. But a lot of times there is a knee-jerk reaction of family members or the patient themselves wanting to drive by themselves. That's a bad move. If you're in the if you suspect feel bad enough that you're having a heart attack or stroke, do not drive by yourself. And because the most common reason why people die when they're having a heart attack is not the heart attack itself, but actually the cardiac arrest or marked irregularity of the heart, where basically the cardiac arrest and the heart is going chaotically as a result of lack of oxygen. That is the thing that kills it. And if that happens when you're on the highway or somewhere in a neighborhood, you're driving on your own, or if you're a family member and you're driving a person feeling bad, you will be totally helpless. You're much better off, even though it seems intuitive to want to go to the emergency room that is next to you, unless it is really a few yards away. Even then, probably having paramedics is probably the safest bet. If you're walking across, and we have seen some dramatic instances when people have an arrest in the parking lot, or they're waiting in the emergency room. It's like ER. I mean, it's like, the serial ER. It's very exciting, but not so much for the patient. It looks good on TV, but when it happens to you, it's not fun. If you're having a cardiac arrest in the parking lot or in an area where you cannot get instantaneous help. If the paramedics reach, they look at an EKG, instantaneously they have the diagnosis. They put you on oxygen, they give you the necessary aspirin and everything, and they are there to revive you in the event you have a cardiac arrest. So it's a simple step of education that patients have to be aware of. When they're having a heart attack, step back, call 911. Wherever you are, attempt to reach 911. If there is a loved one, you see somebody collapsing, call 911, then start resuscitating. So 911 in this country, I don't know for how many decades they're doing it, it is as state-of-the-art as it is, and to the extent now with the latest software, likely the paramedics, when they come to the site and they have an EKG, if they have the software, they can transmit that EKG via the cell phone to the emergency room, as well as potential cardiologists who are on call, so they know unmistakably that the patient is having a massive heart attack, or a heart attack that requires attention, or a heart attack that we can take or a heart problem that we can take more time. We don't have to alert all the resources and run around in a frantic way. And we have another caller here, Linda from Lawtell. We'll take this call. We are coming to the last few moments of this show.
Hey, Linda, you have a question?
Yes, I'm 62, diabetic, high blood pressure, and I've already had an aneurysm on the splenic artery, which has been repaired. I have a zing in my ears, but it pulsates with my blood pressure. You know, with my I can feel my pulse, and I can hear the zing in my ears. Now, I did go to a ear doctor, and she didn't see anything with the ear, and she took a carotid test on my neck to make sure that there wasn't blockage there. So should I be worried more that this could be an aneurysm in my head now causing this, or just something with my ears?
Well, it's an interesting question somewhat, and she kind of answered to some extent. She has a ringing sensation in the ear, is what she described it as a zing, and she has a history of aneurysm on her splenic artery or to the spleen, which was repaired, and that doesn't altogether raise the risk of having aneurysms in the cerebral arteries.
Right.
But the funny ringing sensation in the ears itself is an interesting thing. And she said that as she went to the ENT, of course, the ringing or tinnitus, as we describe it, or there could be other reasons, or middle ear infections or other things, but particularly this really annoying perpetual ringing sensation, which is tinnitus, is a specific condition that ENTs will address. But above and beyond that, from a cardiovascular perspective, more so than an aneurysm, you do have to worry about possibility of carotid blockages, which again, patients in many different ways describe it as a little chirp in their ear, or hissing sound in their ear,
swoosh,
or swoosh in their ear. All these things have been described, which can be due to turbulence, increased turbulence in the arteries when there is buildup in the carotid arteries. You're so close to the ear, if you have your ear to the pillow and you're sleeping, you can hear this, especially at night times, to the extent some patients cannot fall asleep, or they get used to it and then fall asleep. But they do describe it, and certainly doing a carotid ultrasound and detecting that would be appropriate. Also, if the blood pressure in her case is very high, you can feel that pounding, pulsating sensation in one's ears. And so all these things, again, have to be checked. Again, there are rarer conditions which are this so-called fibromuscular dysplasias, or strange condition where there is like a cobweb-like deformity within the artery, which is a congenital problem that can also cause narrowing of the arteries and may create the same kind of sensations. So with that in mind, in the interest of time, we'll talk a little bit about what we can do. And of course, we know once patients do present to the hospital, that's a whole night's discussion of doing emergency angioplasty, balloon angioplasty, and stenting. And how about patients with stroke? Once they do suspect that or if they get up and they have a strong sensation of this kind of a TIA, or weakness, numbness, blurring of vision, slurring of speech, or they cannot walk, what are they to do once they suspect they're having a stroke? Because stroke is a slightly tricky animal. Depending on their risk factors and underlying problems, they could either have a bleed, or they could have this other so-called embolic or thrombotic clot-related mechanism. And the treatment of both these things are completely different. So how do patients react to that?
It's very different, and you have to know which one it is, because if you're treating one and it's the other, and you
could worsen it.
It's much worsened. So, first thing, if it's an acute symptom, the patient needs to get seen rather quickly. There is a timeline of treatment, just like in a heart attack. We have this saying in cardiology that time is muscle. So as soon as a heart attack begins, there's so many minutes before you have a full-blown infarct. Same thing with the brain. There's so many hours that go by that once that many hours has expired, then we see very little recovery. So again, urgency to get treated, seen and diagnosed and treated is pertinent. The first thing they're going to do besides a history and exam, is get a CAT scan, because a CAT scan is going to be a quick X-ray to be able to look to tell. It won't tell you if there is an embolic stroke or a thrombotic occlusion type stroke, but it will tell you if there's blood in a hemorrhagic stroke, and which are rarer, but nonetheless can happen. An embolic or thrombotic stroke will not show up right away on the CAT scan, and at that point, then generally blood thinners are started to be administered. Depending on the risk factors, the age, the timing, a patient may get a clot-busting drug injected in a vein, which then goes throughout the body and starts breaking down the clot and reestablishing blood flow. Now, this is a very potent medication and not to be taken lightly, and there are several do's and don'ts and a big long list of people who don't qualify for that medication, so not everybody is a candidate. But if the right person shows up within the right amount of time, and that's generally within 6 hours of onset of symptoms, they can get the TPA or clot-busting medication in the emergency department.
Indeed, it's just definitely you need to distinguish, and if it is indeed a bleed, giving any blood thinners. Of course, an aspirin itself may not be devastating, but going without really knowing whether it's a bleed or a stroke, the treatments, because can be totally opposite to each other. So unlike the heart attacks, taking blood thinners and responding quickly is of absolute importance, and a CT scan likely would be probably the quickest and the best diagnostic tool in discriminating between the bleed or otherwise. And I also want to make a quick announcement on the 23rd of February, because of this heart health awareness, national awareness month here, we want to conduct a free screening on the 23rd of February from 5 to 7 p.m. at CIS Opelousas at Wayne Gilmore Circle, 1233 Wayne Gilmore Circle, 4th floor, suite number 450. That is a CIS office, where there will be free screenings both for abdominal aortic aneurysms as well as the carotid screening, both of them. And of course, there'll be a variety of other screenings, including sleep evaluations, nutritional and wellness assessments, and demonstrations of heart ultrasounds, and so on. The number to call there, again, these will be announced in the newspapers. We encourage our audience to RSVP and call that number right there. That is our office number. Again, I want to reiterate, this is a free screening program both for carotid disease and abdominal aortic aneurysms on the 23rd of February from 5 to 7 p.m. at our office, CIS, on the 4th floor.
So please call ahead.
Please do call ahead and RSVP. And of course, it's a finite period, and there are limited number of technicians, and based on the time, so please do call in advance. That number 942-3006 that is put up on the screen. Again, we are coming to the last 30-40 seconds of this program, and I think we have taken this time to kind of condense this enormous topic of knowing the signs and symptoms of heart attack and stroke, and both in men and women, how they vary a little bit and at the same time have significant similarities. And once they're detected, how to go about this, and what are the risk factors, and how to modify those risk factors, and knowing them in a timely manner. And there, of course, again, this is all a process, and the heart attack and stroke are tip of the icebergs. And I want to thank all our audience for tuning in and viewing this program, and this will be re-aired again. And I encourage you all to tune in the second Tuesday of each month for more interesting and exciting heart health and vascular health topics. And good evening, and we take leave from OGH and CIS.